Welcome to This Explainer. Today, we're unpacking the clinical journey of a very rare but highly aggressive disease, cancer of the hard palate and upper alveolus. We're going to explore not just the intense surgical treatments required, but really zero in on exactly how and why this starts in the first place. So let's jump right in. When you think of tobacco use, you're probably thinking about lung cancer or throat cancer, right? But the medical data reveals a very specific, highly localized habit that directly targets the roof of the mouth. And that habit is known as reverse smoking, or sometimes called chupta smoking in certain parts of the world. Imagine holding a cigarette, but instead of the lit end pointing outward, you keep the burning cherry entirely inside your mouth. This intense, localized trauma explains exactly why tobacco is a primary culprit for this specific palate cancer. You've got extreme heat literally burning the hard palate day after day, while simultaneously blasting a massive concentrated load of carcinogenic toxins directly into that tissue. It's a brutal combination. To really understand this, we're going to trace the entire life cycle of the disease. Here's our roadmap for today. First, the tobacco connection. 2, anatomy and hidden symptoms. 3, making the diagnosis. 4, the surgical approach. 5, rebuilding the palate. And finally, survival and prognosis. Okay, section 1. The tobacco connection, origins of palate cancer. While reverse smoking is a major, unique driver here, the big, overarching theme is relentless chronic irritation. Traditional tobacco chewing and regular smoking, especially when mixed with alcohol, essentially bathe the mouth in cancer-causing agents. But it's not just chemicals. Everyday physical trauma plays a huge role too. For instance, if someone has a poorly fitted set of dentures constantly rubbing and scraping against the roof of their mouth for years, that chronic physical damage can actually trigger the disease as well. Moving on to section 2, anatomy and hidden symptoms, a different kind of tissue. You see, the roof of your mouth is biologically built like a shield. Think about the soft, flexible tissue under your tongue or on the inside of your cheeks. The hard palate mucosa isn't like that at all. It's thick, it's heavily keratinized, and it is glued incredibly tightly to the underlying bone, the mucoperiosteum. Because it is such a rigid surface, when it gets bombarded by the severe heat and toxins of tobacco smoke, the resulting tumors behave and spread very differently than they would in the softer, squishier areas of the mouth. Because of this rigid structure, a patient might just feel a smooth, totally painless bulge at first. They have no idea the tumor is silently spreading along the paths of least resistance. It travels superiorly, breaking right up into the nasal cavity, which causes unexpected nosebleeds or blockages. It pushes posteriorly into the pterygoid plates, which restricts the chewing muscles and literally locks the jaw shut. And, crazily enough, if it pushes laterally toward the Eustachian tubes, it causes fluid buildup in the ear, meaning a patient might present with a sudden, surprising late-stage symptom, hearing loss. Let's look at section 3, making the diagnosis, seeing the unseen. Once those symptoms hit, diagnostic imaging becomes the surgeon's X-ray vision. Obviously, a punch or incisional biopsy is done first to confirm the histology, to see if it's squamous cell carcinoma, but from there, a CT scan is absolutely crucial for spotting bone erosion. Remember, this tissue is glued to the bone. Meanwhile, the MRI acts as a high-tech radar for something way more insidious, perineural spread. That's when the tumor starts invisibly creeping along the patient's facial nerves. Which brings us to section 4, the surgical approach, clearing the tumor. Depending on the tumor's size, surgeons have to choose from some incredibly complex pathways. If it's a small anterior tumor, they might be able to work entirely inside the mouth, an intraoral approach. But for larger, deeper tumors, they might need the Weber-Ferguson incision. That literally involves splitting the lip to open up the tissue for massive posterior access. Or they might use the mid-facial degloving approach, where they work completely under the facial skin, essentially lifting the face up to avoid leaving any visible external scars. But getting the main tumor out is only part of the equation. There's a major ongoing clinical debate about elective neck dissection, whether to preemptively remove lymph nodes in the neck. Because early palate cancers don't usually jump straight to the neck, surgeons might actually skip this step for small central tumors to save the patient from a more grueling surgery. However, if that tumor is high-grade, or if it touches the inner cheek lining, the buccal mucosa, clearing out those neck nodes becomes highly, highly recommended. Section 5, rebuilding the palate, an architectural puzzle. Okay, so the tumor is gone, but now the surgeon faces a huge engineering problem: rebuilding the roof of the mouth. To figure this out, they use the OK classification system to map out the horizontal defect. Class 1 means just the palate was removed, so the teeth are completely untouched. Class 2 means losing a portion of the jaw and teeth up to one canine. And Class 3? That's a massive total or bilateral loss of the upper jaw structure. Building on that horizontal map, they also use the James Brown vertical classification to see how high up into the skull the damage goes. Types 1 and 2 basically deal with the mouth and the sinuses, but if we reach type 3, things get incredibly intense. The tumor was so high that the surgeon had to remove the actual floor of the eye socket. This means they literally have to reconstruct a new bone shelf to hold the patient's eyes securely in place. So how do they actually plug these massive holes? There are two main options. An obturator is a removable prosthetic. It's basically a highly specialized dental piece that seals the gap, but you have to have healthy remaining teeth to anchor it. If the defect is too large, they perform a free flap transplant. This is mind-blowing. A second surgical team simultaneously takes living bone and tissue from the patient's own leg, usually the fibula, and uses microsurgery to plumb it into the blood vessels of the neck, permanently rebuilding the jaw with the patient's own body. Finally, Section 6, Survival and Prognosis, the data. First, we have to look at the scale of this. Hard palate and upper alveolus cancers are incredibly rare. They make up only 3 to 5% of all oral cavity cancers. And because it's so uncommon, it's really difficult to run massive medical trials, which severely limits the amount of long-term predictive data that doctors have to work with. But the historical studies we do have show a really stark reality about early detection. If this cancer is caught early, in stages 1 or 2, the 5-year disease-free survival rate is a very promising 82%. But, as we talked about, the rigid anatomy of the hard palate hides those early symptoms. So a lot of patients simply aren't diagnosed until the tumor reaches stage 3 or 4. And at that point, the survival rate tragically plummets down to just 48%. It leaves us with a pretty profound final thought regarding the delicate high-wire act of modern surgical oncology. When dealing with an aggressive disease driven by intense habits like tobacco use and reverse smoking, how do doctors perfectly balance the absolute necessity to radically clear out the tumor while fiercely protecting the patient's humanity, their ability to speak, and their very face? It is a remarkable medical frontier. I hope this explainer has given you a whole new appreciation for just how complex that balance really is. Thanks for joining us.